And we're live in 5, 3,
2,
1.
Well, hello, everybody. This is Jens Chapman in Seattle, and it's a great privilege to have you all here this afternoon or evening, whatever time zone you're in. For us, it's in Seattle, it's March 26, 2024. We're past the Ides of March, and it's a huge honor and pleasure, and be a lot of fun to have Dr. Smolinari and Dr. Lenga today to talk about interbody cages and complications. As always, it's so cool to work together with our TBI friends, and maybe Rich and Scott want to say some introductory comments about the topic tonight and what they are looking forward to. But Bob and Emmanuel, thanks for doing this, and we're looking forward to your presentations.
No, I think this is a great topic, one that we haven't heard before, and something that we all do, and we need to learn about how to treat these complications and see how you do it up in Rochester. So thank you both for doing this.
Thanks, Rich.
So do you want to tell us about your presenters and the cases?
Yes, thanks. Thanks for the introduction, Dr. Chapman, and also thank you, Dr. Geyer and Dr. Blumenthal, for inviting us to give this talk about managing complications after lumbar interbody fusion. I would also like to thank my co-presenter, Dr. Molinari. He's been my mentor since I was in medical school at the University of Rochester. And this would be a final presentation as faculty together at the University of Rochester. He still remains my mentor, but I'll be transitioning to the University of Miami beginning next week, and we'll continue to work together and do some presentations together. So the goal today will be to discuss lumbar interbody fusion, indications for or the reasons why we do interbody fusion surgery, and complications that can occur with lumbar interbody fusion and how we've managed those complications. So I'll give a brief introduction about lumbar interbody fusion, and then we'll go directly into some cases and go over some complications that we've had with our patients. So again, I'm presenting today with Dr. Robert Molinari. He's a professor of orthopedics and neurosurgery at the University of Rochester, and has been my mentor since I was in medical school and still remains my mentor today. And I am Emmanuel Manga, and Associate Professor of Orthopedics and Neurosurgery at the University of Rochester. So what are the options? What options do we have for lumbar interbody fusion? So the most common we think about is TLIFs, or transforaminal lumbar interbody fusion. Some people prefer to perform posterior lumbar interbody fusion, PLIFs. We also have the anterior lumbar interbody fusion when we talk about surface area. There's also the lateral lumbar interbody fusion, with different names, L-LIF, D-LIF, X-LIF, with different variations, including O-LIF. And last but not the least, lumbar disc arthroplasty. So this is just X-ray showing different options for lumbar interbody fusion. This is just the what a T-LIF looks like. PLIF, which typically involves, so most people who do PLIF, some would do two interbodies. And A-LIF, lateral lumbar interbody fusion with posterior fusion, and a lumbar disc arthroplasty. So those are the options you have for lumbar interbody options for whether it's fusion or for motion preserving surgery. Why do we perform lumbar interbody fusion? Typically, we talk about spine surgery. Majority of the time, we're doing surgery to accomplish decompression for radiculopathy or neurogenic claudication. So it could be direct or indirect decompression. We do interbody work for fusion or to provide stability. And also, we also perform it sometimes to restore or maintain spinal alignment. What are the most commonly reported complications associated with lumbar interbody fusion? Dura tear, nerve injury and weakness, vascular injury, subsidence, implant migration or graft failure, non-union, and retrograde ejaculation. And we have cases that would go over some of these complications and how we manage them. So I'll go into one of the cases, and after I'm done with the first case, Dr. Molinari is going to go over a few cases, and if we have time, we have more cases to go over, and we'll allow some time at the end for discussion. So the first patient I'm going to present is a 79-year-old male who presented to my clinic several years ago with low back pain, left leg pain, with radiating pain to the left buttock, left posterior thigh, anterior thigh, lateral leg, and lateral ankle, with associated numbness and tingling, difficulty with ADLs, difficulty with sleeping at nighttime due to his pain. He underwent extensive non-operative management and hence the plan for surgical intervention. Past medical history, GERD, non-significant CHF, which is pretty stable. He was seen and evaluated by his cardiologist in a pre-op clinic and was cleared for surgery. On physical exam, as we see with majority of our patients, majority of the exam is typically normal strength. Sensation was normal. The only positive on this physical exam was positive straight leg raise on the left side. So here is X-rays, grade 1 spondylolisthesis, degenerative spondylolisthesis at the L4-5 level. Not so much motion on the dynamic views, on the flexion and extension views. Here's the MRI, and on the MRI, the image right here to the right, that will be the right side, and this is the left side, and centrally, this is looking mostly within the lateral recess. So the patient has severe foraminal stenosis, which may be responsible for his left anterior thigh pain with L4 compression, and also has severe lateral recess stenosis with a small facet cyst over on the left side, which may account for some of the lateral thigh pain and lateral leg pain, which could be related to L5 nerve pain. So I added this image more as a retrospective look, and as we go through the case, you'll understand why I went back and reviewed these images to see what led to the complication that we had from the surgery, and is there something I could have done to prevent this complication, or should I have to perform a different surgery to avoid this complication? And so retrospectively, I added this X-ray, this CT scan. So this is a CT scan, and you look at the L4 and the L5, and you can see the Hounsfield unit. At the L5 is 141, which is not bad, but on the right side is 93. You see on the right side of L4 is 141, but on the left side is pretty bad. So we discussed surgical options, we discussed posterior surgery, discussed anterior surgery. This also happened during COVID, and we had obviously some restrictions with surgery, and the patient was only undergoing surgery due to the significant issues with his ADL. And in trying to optimize, and there was a push to minimize hospital stay, so we opted maybe do an ALIF for indirect decompression with possible perc screw versus standalone if we had good fixation. And so we opted for an ALIF. As you see on this X-ray, the patient went through an ALIF post-op day 1. His pain was resolved. His leg pain was resolved, and the patient was doing very well. And we opted to consider doing strictly standalone. We had good fixation. No concerns with placing the spikes within the bone for anterior fixation. So the patient went home, but about a week after surgery, the patient started reporting increase in back pain, increase in buttock pain, increase in pain down his leg, which was new compared to how he felt before he left the hospital. So when he came, so we opted maybe it's best to bring him back and maybe stabilize posterior, bring him back and see what was going on. So he came in through the came to the hospital for and he felt maybe just proceed with the posterior surgery, which at the time we had discussed placing percutaneous screw. But when he came in, mind you, he never contacted us when he had this symptom. So most of this was discovered when he came in through the PACU, and I saw him in the pre-op area. And his wife was reporting that he's been having this severe pain in his buttock, his posterior thigh. He's having a hard time getting out of bed. She's much smaller than him, but had to help him out of bed to get him walking. And immediately, my concern was the guy, he's likely had a subsidence and recurrent stenosis. And so this is in the pre-op area. So as soon as we got him into the operating room and placed him prone, my first objective was to get an X-ray to evaluate the hardware and make sure there's no complications. And as you see, this is the first image we obtained in the operating room, demonstrating subsidence with collapse of the foraminal space that was previously open with the ALIF procedure. So concern for recurrent stenosis with L5, recurrent L5 stenosis. So the plan initially was to do perc screws at L4-5, but with the recurrent stenosis, we decided to perform an open procedure, still with the idea that maybe I'll just do an instrumentation at the L4-5 level. So went in, uh, performed open decompression, and there was significant stenosis from the subsidence. But his bone quality was so poor that even there were times I was placing the screw doing it freehand, and in my brain, I'm placing the screw in the right trajectory, right position, but the bone felt like butter. I could not feel, even there were times I was surprised, even after we got a CT scan later on, that the screws were actually in the bone. So that's why we had to extend him up to L3 to get some better fixation, and also extend him down to S1 to hopefully get some better fixation. So post-operative day one, the patient woke up, all symptoms completely resolved, significant improvement in his back pain. I was quite surprised, especially given the fixation we had. Patient did quite well on post-op day two. He went home with complete resolution of the symptoms he was having before we took him to surgery. Patient presented for 2 weeks follow-up, some evidence of screw pullout, as you can see right at the top right here. There's a screw pullout on the right side, and you can see the screw on the left side rather at L3, and you can see some of the screw eroding through the end plate. But he reported very minimal back pain. 6 weeks post-op, evidence of further screw cutout, and he reported back pain only when laying down. He was still able to ambulate and still doing well. Has never had any recurrent leg pain or buttock pain. 7 weeks post-op, evidence of further screw cutout, occasional back pain when laying down. And at this point, we're getting concerned that that screw is failing even further. And as you can see on the CT scan, you see this further like windshielding of the screw cutting into this space at the L2-3 level. So part of the concern now is, do we revise this patient, which will mean extending the fusion and then getting further poor fixation, and ended up with more complications? As you see, this can lead to a cascade of more and more surgery. Or do we go back and take out the hardware, knowing that A-lift cage anteriorly could possibly fail even further, and with migration of the cage and lead to further complications? So we sent the guy for a DEXA scan, which came back with a T-score of -1.9 with osteopenia, but personally, I knew the patient had clinical osteoporosis because of the quality of his bone and fixation. So we had the patient started on reclass. CT, as you can see with the Hounsfeld unit. And this is looking on the at L2 on the right side is the Hounsfeld unit is 38. Ideally, you would like to have it somewhere over 130. On the left side is 9.4. So we know even if you go back and say, let's try to extend his fusion, you run the risk of recurrent loosening of the hardware. And at which point do you stop operating, or do you stop doing more surgery? Let's see. There you go. All right, so now is 3.5 months post-op, evidence of further screw cutout, occasional back pain when laying down. And again, as I discussed earlier, we discussed treatment options. So after extensive discussion with the patient, I had an idea of how about we figure out a way to augment or increase the rate of his fusion. We know we have good fixation anteriorly at L4-5, and there's a good chance he's progressing to fusion at that. There's no further migration of the cage. So we discussed the option of either continue non-operative management, extend his fusion, which, as I've discussed with his poor bone, there's a risk for further failure. Remove the hardware, which can also lead to further failure because he's only 3 months out and we're not sure if the A-lift has fused. Enhance his fusion, and enhance his fusion by performing possibly lateral interbody fusion at the L3-4 level, and then later proceed with removal of hardware without touching the posterior instrumentation with the lateral interbody fusion. So I opted and discussed this with the patient and opted to proceed with a lateral interbody fusion. So as you see, I even added some screw to augment the fixation because his bone quality wasn't great. Even added some cement into the bone to get better fixation. So this was done successfully. The patient went home on post-operative day one. So it was just a lateral interbody fusion. As you can see, I've placed him in a Jewett brace. Not sure how much more stability that provides, but maybe the false sense of stability that we keep everything together and tight until he fuses, and hopefully we proceed with just removal of the posterior hardware. So this is 14 months post-op after the XLIF or the lateral antibody fusion. We decided to obtain. He reported no leg pain, no buttock pain, no radicular symptoms. But before proceeding with the removal of the hardware, because of his persistent back pain, which was becoming more and more uncomfortable, we decided to get pretty much full images just to make sure there was nothing further or adjacent segment stenosis associated with the loosening of the screw at the L3-4 level. And the MRI showed no further stenosis. And is the CT scan that was obtained just before the surgery. And as you can see, the screw's cutting out even further. And he will tell you every time he lays down in bed, he gets more and more back pain. So we decided to proceed with the removal of the posterior hardware, took out all the screws through percutaneous approach, and took out the screws and the rods because we're happy. We're a little confident that he had attained fusion at the L3-4 and L4-5 level, at least anteriorly. And so this is the X-ray without significant change just before the surgery. And this is the patient now. He's now 6 months post-op status post removal of the posterior hardware and maintaining stable alignment with almost complete resolution of his back pain. So I'll stop sharing and we'll go to Dr. Molinari, who will present some cases.
Hey, thanks, Emmanuel. Let me just see if I can share my screen and get going. First of all, I want to thank Emmanuel for being a wonderful partner over the last 8 years. I've been practicing medicine for about 35 years now, and Emmanuel, you've been one of the best partners I ever had. So thank you so much, and I wish you all the best in Miami. I'm going to proceed, and I'm going to date myself here and tell you that I was practicing in the 1990s in the advent of the cage and what they called the decade of the cage rage. And what I'm going to do tonight is show you some of the things I've learned, some of the complications I've seen, some of which are not mine, some are mine. I'm going to give you some basic tenets of interbody graft placement first, and I'm going to show you 3 interesting cases. So let's start. And like anything, when you have a complication in spine and with interbody devices, I think as a surgeon, you have to be introspective and you have to analyze why those occurred. And, you can't be too quick to excuse yourself from the blame. So again, you have to be introspective. I can tell you in my career, the majority of my graft complications occurred because of subsidence. It's a very common complication that you see. You saw it in Emmanuel's case, and it happens because of a very simple principle. The bone is osteoporotic, it's weak, and the cages that we put in are very dense. And you have a mismatch in density between the bone and the cage. And when the spine loads itself, the cage collapses. So again, the analogy is like, putting a rock in between eggshells and expecting the eggshells to hold up. And it just doesn't pan out. I think it's important to understand simple biomechanic principles when you use cages. And again, in the 90s, I don't think people really understood this all that well, okay? Why do we use a structural graft up front? What's the advantage of it? Well, if you look at the diagram here, it changes the loading of the spinal segment. It changes it to bridge fixation. It changes it from bridge fixation to dynamic compressive load bearing. So again, when you put a structural graft up front and you put instrumentation in the back and you compress over that structural graft, the entirety of the structural graft is loaded in compression. And so is the posterior aspect of that segment. It's all loaded in compression. It's a very favorable segment for healing and environment for healing. So again, that's the principle of using an interbody graft. But I think, we've kind of failed in understanding that principle over the years. People often don't combine their interbody grafts with posterior fixation. If they do, they often don't compress on that interbody graft. And again, they don't take advantage of the tension band of the dynamic compressive principle. Now, Charles Edwards told us in 2001 that there's a problem with the vertebral body as we age. It gets osteoporotic. And when it gets osteoporotic, the best portion, the strongest portion is the peripheral, 2 millimeters of the end plate. The end plate's very thin centrally, but if you're going to put a graft in, you need a wide graft and you need to really try to incorporate the periphery of the vertebral body. So bigger grafts are better. Okay, and Hasewaga, again, the same period, did a compressive study on cages and said, wider the cage, and avoiding cage placement centrally gives us the best compressive strength of the graft. So what I realized over the 90s decade is try to put a wide graft in, try to do a good decompression, a good discectomy, try to maintain as much of the end plate as you can, try not to violate it so you're into the cancellous bone. And again, really, this is just good carpentry principles. And when you're going to see some of these complications, you're going to realize that carpentry principles aren't really adhered to. So again, we know this, right? And I like to give this slide in many lectures that I give. There are my top 10 reasons why surgeries fail. And you can apply this slide to almost any topic in spine surgery when you talk about complications. But what I want to do tonight is just show some of these with respect to interbody grafts, okay? So the first one is, the wrong surgeon. Right? You're the wrong surgeon. You're in over your head. You didn't ask yourself, can I handle the complications from this procedure? In the 90s, people often went to these company courses. They learned about interbody grafts. They may have done it on a pig. They may have done it on a cadaver, but then they went and started doing it in humans, and very few really understood why they were doing it and the principles, the biomechanic principles of interbody surgery. Okay, so let's start with the first case. This is a 68-year-old female. This is back in the 1990s. She had a simple degenerative spondylolisthesis. And you can look at this and say, this is a home run. This is a case that any fellow wants to do as their first case. You do a decompression, plus or minus a fusion. You can argue just an instrumented posterior lateral fusion, and that's it, okay? And the multiple studies, including a sport trial, shows that these do well with just a decompression, and if it moves a posterior lateral fusion. That's all that's needed. So, all of us would agree that this is a simple case, okay? But the reason I put this in the wrong surgery category is this is what the surgeon did. This is a surgeon who went to a course on threaded cages. There were bone dowels put in from the back. And this is really in the decade of the advent of the PLIF, the posterior interbody fusion surgery. And you can see what the surgeon did. He resected the entire pars here on this side, okay? And on this side, he resected almost 90% of it. And when you went to these courses, they told you that the integrity of the segment was maintained if you put big cages in and stretch the annulus anteriorly. So a lot of surgeons left and said, all I have to do is just put big cages in, stretch the annulus, and the segment is stable, okay? You guys know what the next slide's going to show. You know what it's going to show, and here it is, okay? This is what happened to this poor person, okay, who had, again, just a simple degenerative spondylolisthesis. And you can see there's non-union, okay? There's complete destruction of the posterior elements with instability. There's coronal and sagittal decompensation. So this woman went on to a horrible experience postoperatively. She had non-union, as I said. She had spondylolisthesis. She had coronal decompensation. And this woman was miserable and didn't trust surgeons at all. I saw her for an opinion. I offered surgery, and you know what? She saw many surgeons, and she was afraid of spine surgery at this point in her life. And she said, never again will I do this. I'm miserable. My life is ruined. So I say, this guy learned how to do this procedure. The guy was known as a PLIF surgeon because he treated everything with PLIFs. And you know what? There's the old adage, if your only tool is that operation, if it's a hammer, then everything else is just a simple nail, okay? So here's case number 2. And again, this is another reason why surgery fails, interbody surgery fails, is that you're not using the interbody devices correctly, okay? This is a 60-year-old male who had isthmic spondylolisthesis, who went to a surgeon who treated the patient with a gill laminectomy posteriorly, and then ALIF screws, threaded bone dowels, anteriorly, because he was taught that threaded bone dowels that are very rigid and wide will stabilize a spine segment. Okay. And again, the cage was placed laterally here. This is just horrible surgery, horrible decision-making, big surgery for a patient. And the patient got no better. In fact, worse. You can see on the CT myelogram, there's a complete cut. This required a big anterior and posterior reconstruction. And it's just an example of mismanagement with patients with interbody devices. And this was widespread in the 90s. You saw this all the time because people didn't understand how to use them, and they didn't understand that they can potentially destabilize the spine from a posterior approach and what was essentially needed. So with that, I'm going to show you, I'm going to date myself again. I'm going to show you, this is a case I did in the 90s. I was an Army surgeon, and this is a case of a 35-year-old active duty U.S. Army soldier. He had chronic back pain, and he had 15 years of U.S. Army service. He needed to get to 20 for his retirement. He had physical therapy, he had chiropractic care, he had all kind of physical duty restrictions, and his commander was telling him that it was time for him to get discharged from the Army because his back, he couldn't carry a rucksack and his back was miserable. So it's about the time I started working at the Army facility, and I got an MRI in him, and sure enough, he had single level disc disease at L4-5. He had an annular tear. He didn't have any instability on flexion extension views. In fact, he really didn't have much stenosis, and his main complaint was 100% axial back pain. So I thought this guy, who was a motivated soldier who really wanted to get back to duty, would be a great candidate for a single level fusion procedure in the spine. And I felt because of his activity level, he would be great to do an operation where I can put the L4-5 segment in dynamic compressive weight bearing. And that's what I did. I put a Brannigan cage. These were Brannigan cages were like carbon fiber devices that were radiolucent, and I put autograft bone from the iliac crest, and I did a concomitant instrumented posterior lateral fusion, and I fixed the segment in compression. I was very, very happy with the operation, and the patient stayed in the hospital 3 days, and then he went back to his unit. However, at 2 weeks, he returned with a superficial wound infection. The reason it's superficial is the staples were red. It was draining a little bit. And as a young surgeon, I said, I'm going to take him back to surgery and explore the wound. So I took him back to surgery, opened the wound, washed out the superficial area, saw that the fascia was tight. And in that time in 1997, I said, okay, the fascia is tight. This is just a superficial wound infection. So I closed him up, put a little drain in, kept him for maybe 48 hours and sent him home on antibiotics. Well, I think we all know now, right, that when a wound has a problem, right, you always open up the fascia. You always explore the deep fascia. You never just declare something a superficial wound infection without inspecting the deep fascia. But this was me right out of fellowship. I hadn't had much experience working on my own, and I was convinced that this was just a superficial infection. So that was 2 weeks after. So 3 months after, I'm happy. I'm home at night, and I get a call from the emergency room that he's in the emergency room because his back pain is worse. It's a 10 out of 10, and the emergency room did some blood work on him, and he had a really high ESR, really high CRP. He was febrile, and he just had 10 out of 10 back pain. So I ordered an MRI, and this is what the MRI looked like. To me, it was pretty much unremarkable. And again, you can see the date. It's December 2001. Okay, many of you were probably in their infancy then, or in early childhood. But I looked at this and I said, my cage is in good place. The screws are in good position. The canal is decompressed. I don't see anything here that really strikes out as being abnormal. Maybe a little fluid back here. Maybe, but I said, okay, let me admit him. Let me get an ID consult and let's see what happens. So that's when I got an ID consult and said, okay, let's put him on antibiotics. So I have him in the hospital. It's 5 days later, and he complains of acute left leg pain, really bad leg pain in the left L5 distribution. So I repeat the MRI, and here's the MRI just 6 days later, and you can see what it shows right here. Okay, he's got some EHL weakness, but really new symptoms for a left leg pain, and that's what generated this MRI. And look at what's new in the period of 6 days. Here, there's this big mass right here, and it looks like it looks like a fluid mass, and it looks like it's circumscribed, and here it is on the axial view. So you can see my Brannigan cage right here. You can see this is a big, what appears to be epidural abscess. It's connected to my cage. It's pinching the nerve root. And here it looks like there's still fluid posteriorly here. So I goofed on this case at 2 weeks. I should have opened him up and I should have washed him out, because my suspicion is he probably had a deep infection at 2 weeks that I just neglected. I missed. I didn't open up the fascia. Okay. So what do you do now? Okay, here's his x-rays. Okay, it was so quick to get MRIs, but what about standing x-rays? Here are his x-rays at 3 months, and you can see he's got a lucency around this cage. So He's got recurrent wound infection now. His labs are unchanged. He's 3 months post-op, and he has a very bad infection going on. So we have an expert panel here, okay? And I'm going to open it up to the expert panel and say, what would you guys do? Because I'll tell you, I was a year, not even a year, well, maybe a little bit more than a year out of fellowship here, year and a half or so, and I'd never seen this before. So, I wasn't sure what to do. I thought about it a lot. I asked a lot of questions. I'll show you, but I asked the panel, what would you guys do?
I think Jens has the most experience with infections as all of us.
Well, thank you so much for that privilege.
I don't know, Jens, we must be pretty close.
They all Bob was in the Pacific Northwest. He knows how that happens. They all drift to the West Coast. They either go to Sig Bourbon or they come up north, wherever they divided. Sig's online also. He can tell us a bit about that. I take the hardware out, and I take these infected cages out from the backside. I'd put a PMMA spacer in there that I make myself, and I would put new posterior hardware in there, and I would later on, either through a magician XLIF surgeon like Dr. Menga or through my partner, Dr. Uskulian, have that PMA spacer taken out and replace it with a new titanium mesh cage and probably off-label BMP. Sig, what do you think? I know Sig is in the panelist box. I don't want to put him on the spot, but that's what I would do. I definitely would put a PMA spacer in there and wash it out. I use these thoracoscopy irrigators, do a bilateral discectomy, so I can do a through and through washout, so it's not just strolling water around, and wash out with 9 liters. One more time, yeah. Sig, are you live? Can you go live, Sig? I don't see the microphone on. So
Jens, can I ask you a question? So you said you used the PMA spacer with the antibiotic, I'm assuming?
Yeah.
Okay.
So I make Reza is asking me, because Dr. Shazim is asking me, how do I make those? I could at a future point show cases with that. We have Neil Patel here also, so he's seen me do that.
Yeah.
So basically, I would take the hardware out, do bilateral discectomies, remove the cage from the back, destroy it either with a drill or fish it out, clean the end plates up with osteotomes, and then I put in this thoracoscopy irrigator. This is a very elegant tool that I stole from the general surgeons. It provides a very high volume suction irrigation system. I run 9 or 12 liters through it until the bone ends are nice and clean. And then I would put new titanium screws in there. Sorry, you're out of focus. Neil has seen me do this plenty of times. We then mold until it's doughy, methyl methacrylate with tobramycin. I add 1 or 2 grams of vancomycin powder in it. I mold it until it's very doughy, and then I make my own little poor man's peak spacers, like thumb size, stick them in there, mold them in there until I have a nice end plate fit, put new titanium screws in, gently compress it down, and then wait for 3 months. In some patients, it actually forms heterotopic bone around it. In others, and I opportunistically do a posterolateral fusion, fish that out with a XLIF procedure. And again, I thank my partner, and Dr. Menga has shown his XLIF capabilities in his previous case, which was a cool case to see, have that fished out and put an XLIF spacer in. So that's my thought, but it's a very powerful way to get a very high local concentration of antibiotics in, and the antibiotics are supposed to last somewhere up to about 3 months. And Cliff, thank you, Cliff, is also so cool. Thanks, Cliff. Do you remember Dr. Menga? You two work together. It's so cool to have you two together. Yeah, we use them actually as spacers also, and we can show that. Diagnostic approach, Dr. Abdel Chachman has a question. Diagnostic approach for early infections. Bob, Emmanuel, do you want to talk about that? Dr.
Yeah, I think labs and the MRI, the MRI and contrast MRI is probably the way to go here. But you can see that you can get fooled with that. I got fooled on the MRI a week before. I just didn't see it. So I would still do the MRI. I would still do the labs. I knew this patient had an infection. I just didn't see the epidural abscess, and it didn't develop rather quickly.
Yeah, I was
And
gonna
was it
say,
stabbed?
between the labs and the MRI with and without contrast, a lot of times we do some of this interbody work and do posterior work, and then if you end up with an infection, I think it's not uncommon that we don't see much within the anterior space because of the increased signal, depending on what type of antibodies you place in there. So it may be tough to see any inflammation surrounding the interbody, but I think part of it sometimes we just have to assume that it's connected to the posterior lateral space and it's likely infected. I think we get away a lot of times with just a washout and washout, and that's it. But for some of these patients, you can end up with complications like this, where they don't respond well to the antibiotics and continue to progress with the infection.
So the other
That
question,
may have been one of my questions is, did for such an aggressive infection, did the patient have any risk factors, medical comorbidities that, like you said, 90% of the time, posterior infection, little washout, you're good. Why did this turn into something big? Was there any patient factors?
This is a 35-year-old U.S. Army Ranger who has no medical problems whatsoever. So very atypical. But really the point I need to make here is, when I first started to do PLIFs and people do TLIFs now, I took out the majority of facet joints. And again, the stability was provided with the screws. So you're at 3 months now, okay? And you're expecting to go back where you're around the dura, the anatomy is all distorted. And my concern here was, how am I going to get this thing out without damaging the nerve roots? So any thoughts to how do you go back on this when it's a big scar ball posteriorly? You have any tricks, Jens? What do you do? I've done 3 of these now in my career, and thank God it's only 3, but this was the first one. And again, I had no experience whatsoever, and I'm on my own here. So how do you get this thing out? Do you do anything differently? How do you deal with the scar, and how do you preserve the nerve roots and get this out safely?
Sig has joined us, by the way, but we basically dissect out dural sac, healthy dural sac above and below, and it's not that bad. I know, I mean, I have to do so many revision surgeries, I probably can inure to it, but we dissect out the dural sac above and below and clean out the nerve roots, and the pedicles are your friend. And the best advice I have is establish the posterior body wall, Woodson elevators. I have a variety of those, and then osteotomize above and below the cage under C-arm guidance so that you have a healthy new start. Loosen it up medially, laterally, and I have a variety of kind of long snaps that I can then mobilize on there. The simplest thing is if it's allograft or if it's like a P cage, you can destroy them usually with a sharp, nice Midas tip, and I have a variety of Midas tips, and we run it in there and then again irrigate it out afterwards. I like one of your partners at TBI, Dr. Fisher, mentioned going anteriorly. Of course, like at L5 is one, it's very nice to go anteriorly. Not any issue at all, no complaint. At 4-5, sometimes our vascular surgeons have to do more mobilization of the vessels, and especially with an infection, it can be ugly. But whatever you feel comfortable with, I usually feel very comfortable with coming in from posteriorly and gaining access to Cameron's triangle and releasing the roots.
Okay, that sounds great. And unfortunately, when I did this in the early 2000s, it didn't work out that well for me. I had a big dural tear trying to get this thing out. So now, okay, the cage was loose, but I have CSF come. I'm talking intraoperatively now. I have a CSF leak, which is ventral. I can't really see it. I did get the cage out. I was able to get the cage out. I think all the panelists would agree that the instrumentation has to come out. The screws were loose. Everything was loose. So now everything is out, okay? I have a CSF leak. Any comments from the panel? What do I do with the CSF leak, and what do I do with wound management? Again, I'm a year and a half out of fellowship. I don't have anybody here. I'm intraoperatively. So what do you do? What would you guys do? You got an infection and you have a CSF leak.
Sig Bervin is live now. Sig, help us.
Yeah, I apologize. I couldn't speak up. I was in the OR, and some of the computers here don't have a microphone. So, Bob, great case, and thanks for sharing this. This is a tough situation. Now, I heard Jens say trying to get these out from the front can be a little bit easier, either direct lateral or anterior. And a trick to that, I'll just point out, is taking a 3.5 millimeter drill and then tapping. So drill into the cage in the peak, then tap into it, and it's easy to pull it out. And I usually do that kind of from an anti-psoas type of an approach. but now you create a scenario where you're in the back with the dural tear. And the one trick I think Jens alluded to is trying to get to an area where there hasn't been prior surgery. You took out the whole facet joint, so literally just kind of hugging the pedicle above and the pedicle below, and trying to get onto a plane with this bone, and wherever you can, creating a new plane in the epidural space rather than trying to go through the scar. I think that's the one thing I do a lot of revision, posterior decompressions, and trying to create a new plane. The easiest is, doing a facetectomy where there wasn't a facetectomy, but in your case, you had a facetectomy. Now there's a dural tear. This is where it's good to have a friend, and we have a lot of trainees on this call. And when I mean it's good to have a friend, you're saying, Bob, you're a year and a half out, and this kind of situation where I think regardless of whether your assistant is the level of talent of your assistant, just kind of sharing this, especially this tends to be in the middle of the night, and for the junior people, try and have an opportunity to do these revisions maybe with somebody sometimes, and find at this point your version of Bob Molinari at this age, right? But if you're a junior person, find somebody senior, because it's really miserable. On a ventral dural tear, that's a tough problem, Bob, and I'd certainly try and find it. I did this under a microscope. Try and find it and stitch it, and if you can't, I'll suture a DuraGen patch. I use a suturable DuraGen and put it ventral to the dura, and just get it as tight as I can. But instead of infection, that's a particularly unpleasant experience.
So I'll tell everyone what I did. So I got the cage out. It was loose. Again, the screws were loose. I took everything out. I couldn't get to the leak. I couldn't get to it. It was ventral. And all I did is I washed everything out. I did a thorough washing debridement from the back. I wouldn't say I resected all the facet joints. I resected a lot to get these cages in from a bilateral approach, but not all of them. Okay. And what I always do is I do a concomitant posterolateral fusion when I do an infection. And I washed out the bone was there, I washed it, whatever was loose, I washed it, but I also put it back after I washed it. So essentially, this is what I did. So this is an I&D. I removed the implants, and this is my posterolateral bone graft that I put here. And one of the other reasons why I like to show this case is whenever I do a PLIF or a TLIF, I always do a concomitant posterolateral fusion. I think that's important. And when I looked at my early PLIF, my first 50 PLIFs that I did when I was in the service, I found that you don't always get both an anterior and a posterior fusion, but you usually get one. So I like to put bone posteriorly because it's easy to do, and I use iliac crest autograft. I don't use any coral or any bone products. BMP wasn't out at the time, but this is just iliac crest bone graft, and this is 6 months after his procedure, and you can see I got lucky here. He didn't slip. Not only did he did not slip. You can see my wide. If you look here, you can see the wide resection I did to get the cage out and to put the cage in. It's a big stabilizing section. But what saved me here was I took the time just to expose the transverse processes and throw some iliac crest bone graft there. And I'm a big advocate of doing a circumferential fusion when you do this. Now we're quick to do perk screws. We're quick to just put hardware in, but we don't really think about the reason we're there enough. And the reason we're there is to get a fusion here. So you can see there's a nice solid fusion here at a year, okay? You can see the MRI, everything resolved. You don't even see any signs of residual CSF at a year. And I can tell you that this guy went back to full duty in the Army. And despite all the complications, anxiety I had, shortly out of fellowship and the loss, this guy got better. And I show this for several reasons. Not only is it a cage complication, but I think it really points to the importance of doing a concomitant posterolateral fusion when we do these procedures. So I'd like to hear some comments again, any points from the audience before I go to my next case.
Bob, you bring up a great point, because I would say that most surgeons don't know how to do a good posterolateral fusion. We're of the age, my partners and I, that's what we were raised on, how to do a good posterolateral fusion. And I would say most people that do TLIFs that say they do a posterolateral fusion, they're not doing them the way we were taught to do them, in terms of exposing the TPs, the outer face of the facet, and things like that. So that was a nice salvage. But I do have one question for you. How did you manage the dural tear? Obviously, you couldn't repair it because ventral? Did you just pack it or?
So what I did is I put some sealant on it. Okay, I washed out everything. I put some sealant on it. And then this was the early days. These are the early days of me starting to use vancomycin. I was using vancomycin early on. We were one of the hallmark papers on vancomycin with 1,500 patients in it. And I was using it back in the late 90s. When I was in the Army, I was actually using it before anyone really talked about it. So I did have some vancomycin in the wound, and I put just a small Hemovac drain in, and I closed the fascia very tightly, but I didn't put the drain to suction. I just put the drain I left the canister without any suction on it, and I left that in, and I just let it drain the gravity essentially, and I took it out maybe a couple of days post-op. But I got lucky here because the CSF leak didn't turn out to be a problem post-operatively. He didn't get meningitis. The ID people put him on. Yes, it was Staph aureus. I don't know why he got the procedure. Actually, I do know why he got the procedure. The infection. The reason this guy got the infection is he had a routine wound problem post-operatively at 2 weeks, and I didn't open up the fascia. So again, I learned early on in my career that you better open up the fascia on every wound problem you have, and you better inspect underneath it, because that's the way you do a thorough debridement. So, gone are the days where you just think about doing a superficial debridement down to the fascia. So I think this case really demonstrates that. So the dural tear really didn't become an issue other than, intraoperatively, where it caused a lot of anxiety.
Great principles, Bob. Great honesty. Just really well handled. And I totally second what Rick said in terms of a posterolateral fusion is a phenomenal thing, and doing it properly in this MIS era is becoming a lost art. Did you actually put bone graft into that disc space? I mean, this looks phenomenally healed. Or was this the benefit of an inflammatory disease process that eventually turns osteogenic?
Jens, when we first started learning how to do the PLIF, right, we were taught to pack bone anteriorly, right? So you took your iliac crest bone graft, before you put your cage in, use the tamp, and you pack the bone anteriorly before you put your cage in. So I did do that, but I just think I got lucky here. That disc space was infected. Yeah, now you would say, wow, if it's a disc infection, it should heal, it should fuse, but that isn't always the case. And again, for me, I'm going to point out the fact that whenever I do a single level fusion, if I'm using an in-body graft from a posterior point approach, I'm always doing a concomitant iliac crest bone graft posterolaterally.
And Bob, I have to compliment you. You have nice lordosis there too. I don't know how you planned that.
Yeah, I don't think I thought about that, Rick. Okay, I got one more. So we have time for one more, Manny. How much time do we have?
Yeah, I think we have time
minutes.
to go over maybe a quick one more, and then we can ask about the audience, see if they have any questions about all the cases. Yeah.
Okay, again, 52-year-old, long history of back pain. This woman had fusion surgery a year ago that was complicated by postoperative weakness and dorsiflexion and paresthesias. Here are her x-rays at a year. Here are the post-op x-rays from her index procedure. Again, this is the time of, the PLIF and cage rage and the threaded cage rage. She said she was made worse by her initial surgery. She's got worse back pain than she ever had, and she's got this right radicular neuropathic pain that is incapacitating. She had PT. She had an injection that gave her just a little bit of temporal relief, but not much of her back pain relief. And she's been in pain management. She takes narcotics. Her VAS is off, 9 and sometimes 10 out of 10. She was a smoker back when she had her surgery, but she says she quit smoking. And again, here she is. This is her when she's in the office. She is a workman's compensation patient who applied for disability. She does have a history of depression. And again, I said she's a former smoker. No other major medical problems other than, now her back is killing her. It looks like the surgeon tried a TLIF approach. Okay. And it looks like the surgeon used one threaded cage that now has caused at a year instability by resection of the facet joint. You have subluxation of L4 and L5, looks like a grade 2 spondylolisthesis. And here's the CT myelogram that shows that cage is actually in the canal now. It's actually close to the canal, and there's impingement. So you can see, the facet joint's completely gone, okay? And now the question is, how do you handle this? What do you do now? And what's the I can say, what's the pain due? Is it due to the slippage? Is it due to traumatized nerve root? Is it due to I don't know. I don't know it could be all of the above, right? So what's her pain due? And now what's the best surgical procedure, if any? So I'm going to open this up again. Again, these are early cases from my career. I think I've become a lot wiser, looking at these and learning from them and talking to other people about it early on, in the late 90s and early 2000s. So I'm going to open this up to the panel and say, what would you guys do now, if anything?
Well, the good news is that you can counsel the patient that since you didn't do the index surgery, whatever I do may or may not help you, but here's my plan.
Yep. Well, what's your plan?
I think that's going to be a tough one to get out from the front. We talked about pulling out TLIF grafts from the front. It could be done. That might be a tough one to do. Like Jens said, there's certainly a way to find some virgin tissue above and below and perhaps dissect your way to where this cage is impinging on the nerve root. You got to get it off the nerve root. I mean, that's number one. And then create some stability, either contralaterally or, or anteriorly at that point. But I think it's just going to be hard to get the whole graft out anteriorly. What do you think, guys?
I agree, Scott. I think it would be hard, but on the other hand, if you could get it out, then you can put a nice big graft in there. And I might try, because I think to go at it posteriorly is going to be so much scar tissue around the nerve and the dura. And you
Yeah,
can
and I think
dissect
whether
them,
you
but
do it anteriorly or posteriorly, you probably are going to end up with a battered root syndrome, and it may, the leg pain may or may not get better.
yeah, I mean, it's a toughie. I think it's going to be hard either way.
Was that a cortical threaded cage, a cortical bone threaded cage?
That's what it looks like. Sig, I'll go back. That's what it looks like. Looks like a bone dowel, right?
Yeah. Yeah, so I think that's important. There's differences between titanium peak and cortical bone. Looks like this is cortical bone, and there's some real advantages to that. Just like peak, you can break it. You can use the osteotome and break it. Um, Again, I tend to find this easier to get out from the front, to avoid the nerve root problems that you had last time. So I would tend to do this from the front and just do a full discectomy, get down onto the bone, and then you can crack this and pull it out from the front. I'm going to back this up anyway, so I take a look at it from the back. But I think if you get a good interbody graft from the front, that's going to be a good solution.
Yeah.
Plus from the front, you can get a really, once you get this out, if you can get it out, you can get a nice indirect reduction with a nice anterior interbody graft.
Jens, is this one you can get out from the back?
I would certainly try
Bob,
that. I mean, the myelogram shows me that this man has if you go forwards again, a severe stenosis. Looks like it's at L3 to 5, if I do the math correctly here. So this patient, for me, first and foremost, needs a neural element decompression. I would do that posteriorly with facetectomies, and I would consent and plan the surgery for an L3 to 5 decompression. I would have little doubt, and I would do a central decompression here. I would strive very carefully and do my best to avoid a dural tear, but that's the nature of the game. To get that cage out from the back, and then do whatever it takes to realign the spine and fuse them from the back. And I would use PLIFs in there. Probably, again, if my math is correct on the myelogram, L3 to 5.
Yeah.
Hey, Bob, go back to the CT before you go forward. If you look, there's almost like a rim of bone behind the graft, and you can see it also coming laterally. So that's going to be a little bit of a bear. Do you see what I'm saying?
Yeah.
Right behind the graft.
Yeah.
Towards
Yeah, Dr. Emma, I think, yes, I think for someone like this, given if you're on the lateral, there's pretty significant collapse, and then with the bone also subsiding through the end plate, I think I also feel more inclined because yes, you can do a disectomy and then get in that cage, get in that bone graft out. Sometimes maybe the superior end plate of the superior aspect of the bone graft may be fusing into the subsided bone. So getting it out adequately, and also in the process of putting in the ALIF cage, I think I'll get concerned that I may end up pushing more bone into the canal. So I think for something like this, I may go posteriorly and do the decompression at that level and also at the adjacent segment. with the severe stenosis as we see on the CT myelogram. And
you would do it all from the back, Manny?
I would try to do it all from the back.
Okay. The rest of us, we agree, circumferential, we go front back or back front. Okay.
Yeah.
Yeah, and again,
Yeah.
we know, and I'm just going to say, I don't have much time, but Gertzbein told us that when you have these pseudos, all right, circumferential fusion gives you procedures give you the best fusion rate. You don't always get the best results, and especially if the patient's taking narcotics, and if the patient's out of work. But we know that, and Todd Albert told us that if there are mitigating factors here, this was a work comp patient, had abnormal neurologic findings, had perioperative narcotic use. We know that they do worse than patients who don't have those variables. So what was done here was an anterior and posterior procedure. Okay, screws weren't put in on the other side. A big graft was put in the front, and a decompression was done posteriorly, and that's it. And is the patient better? Well, this is at a year. The patient had some improvement in the leg pain, still had some back pain, but was on full disability. So essentially, that's how I handled that one. Again, shows another interbody graft complication. Okay, and what I showed tonight were several interbody graft complications, and just a way to think about what we do when we put in these dense interbody grafts, and especially in people who are older who have osteoporotic bone. And I'm going to finish with one other point, which I want to make to every young surgeon that's out there tonight. And there are companies that describe these indirect decompression techniques for elderly people with spinal stenosis, where they have you do a lateral procedure and put an interbody graft in. Okay, often these interbody grafts are small. You may get good height distraction when you put it in, but when the elderly person stands up with their osteoporotic bone, the whole thing subsides. So for me, the point I want to make tonight is that indirect decompression from the front is incomplete decompression. So please be mindful of that. And the best way to decompress spinal stenosis is do it directly from the back with a simple decompressive laminotomy procedure. So that's all I have tonight. Any other comments are welcome.
Sig, so you've been very patient there. Thanks for joining us. Any thoughts? I mean, I think that Bob and Emmanuel have shown some really good cases. You missed the first one, but the fit part, the vertebral end plate being so tied to the apophyseal ring were some really big teaching points. Any thoughts from your end?
Yeah, I'll just it was a really good overview, Bob, and I think your final points were excellent. What are your thoughts about when we need interbody fusion? The real advantage you pointed out is the indirect decompression, but do we need interbody fusion at every level? So, for example, if we're doing L2 to S1 or longer than that, when do we need interbody fusion, and when do we not need it?
So for degenerative cases, I'm going to tell you rarely, Sig. I think we overuse it, and I think we have a financial incentive to overuse it. We get paid more for doing it. So a lot of surgeons will add interbodies to degenerative spondylolisthesis that may be inherently stable, have a little bit of motion without kyphosis. For me, I rarely use interbody procedures. I'll use them only on occasion in degenerative spondylolisthesis when there's segmental kyphosis, and I want to do my best to correct the kyphosis. Otherwise, I will not use it. I used it early in my career in young, active people who were physically fit and had vigorous exercise routines. I used it on them, but I probably overused it back then. I think the structural graft up front is needed when there's an anterior column deficiency and a deficiency up front. But otherwise, I think it's overutilized. And again, I'm going to say I think it's done because there's a financial incentive to do it.
That's a really useful perspective to hear you say that with your experience, and I don't disagree. I have to admit, if there's deformity, I'm certainly using interbody support for the indirect reduction is useful. But I agree with you. I don't think we need it at every level, and a lot of times I think we're seeing it at every level, and it's actually almost locking a deformity in place and preventing us from being able to get correction in the back.
Yeah, no, I think I would agree with Dr. M. I think we talk about this a lot during our indication conferences, as far as in discussing with our partners, or even our residents and our fellows, when do we use interbody? I think I tend to use it in degen cases. So when I use it for deformity's sake, I typically would only put anchors at one level. So that way I still maintain flexibility when I flip the patient to get that correction with compression, with posterior column osteotomy. In the setting of degenerative cases, I only use interbody if I feel, especially for patients with symptomatic severe foraminal stenosis bilaterally. If it's unilateral, then I still feel like I have that bone-to-bone contact within the facet joint, that once I do my decortication, I don't need that much space for migration of bone for fusion with a posterolateral fusion on the contralateral side. But if I have to, if symptomatic foraminal stenosis, if I have to take out or disrupt most of the facet joint on both sides, that's when I incorporate a TLIF to make sure that I don't lose out on the fusion. And I'll do a TLIF, and then as Dr. Molinari described, I'll make sure I do good bony posterolateral fusion, especially on the contralateral side of my TLIF, so I don't end up with a calcification or ossification over the nerve roots on the TLIF side.
Well, guys, this was a very, very interesting conference. I think one of the things that we see is that we're always going to get referred in ill-advised constructs from our communities to have to fix. But I think that what perhaps this meeting can do as we get more and more people that Jens has put together through Seattle Science is perhaps a decreasing of these type of complications by better education of our colleagues on how to treat, for example, tonight, degenerative stenosis and spondylolisthesis in the elderly, to hopefully avoid those kind of complications. And, we've had, these kind of meetings before where we've talked about it from different centers, and hopefully we can keep educating the folks in our community so that we can see less of these complications.
Yes, this was great. Thank you to the folks from Rochester, and good luck, Emmanuel, on your trip to Miami as you take a new position. And Bob, thank you for these great cases.
Thanks, Rick.
Thank you.
Great discussion. Thank you, everybody. Please claim your CME credits. And good. And thanks, Cliff, also for putting the annotations in there. It's always much appreciated. Bob, Emmanuel, absolutely outstanding. Thank you all for your visits, and many, many greetings to Texas. So I'll take care. Bye-bye.
Have a great night, everybody.
All right. Thanks, everyone.
Thanks.
Good night.
Thanks, Ed.
Bye.
Thank you, Dr. Minga. Thank you, Dr. Molinari.
Oh,
Appreciate
thank you. That was wonderful.
job. It was great.
Thank you. Appreciate it. All your help. Thank you.
You're welcome.
Okay.